Well, hello again everyone. Myself Utpal Shashanka Boru, a student of Lakhimpur College of Veterinary Science, shall be discussing today on the topic shock, prepared by my colleagues Krishnankan Roy, Liana Medhi, Mausumi Bharali, Mridul Hassan. The diagrams are illustrated by Kuntal Kashyap Buragohai. Now before we proceed further, this is a disclaimer that this presentation has been prepared to the best of the abilities of the UG students of LCVSC to provide as much as accurate information as possible. However, we do not encourage people to use this information provided in this presentation for scientific work without cross-verifying the data. This is only for educational purpose and not for commercial purpose. Further, the information provided in the presentation should not be used for the treatment without consulting a registered practitioner. With that being said, let's move forward. Here are the contents of today's presentation. We shall start with introduction to shock, then etiology and classification, then coming on to its pathogenesis and clinical findings of shock, coming on to diagnosis, then treatment. Now, definition of shock. Shock is been defined as the generalized acute reduction in the perfusion of tissue resulting in oxygen deficiency in cells. It occurs due to an imbalance in the intravascular and extravascular fluid and characterized by reduction in the effective circulation and reduction in the arterial blood pressure. Now, the lack of effective blood flow leads to derangement in the cellular metabolism and ultimately cell death. Inadequate tissue perfusion and removal of cellular waste product leads to failure of oxidative metabolism that can involve deficit in oxygen delivery, transport, utilization, or a combination of all three. When left unchecked, shock results in global cellular dysfunction, leading to entire organ dysfunction, progressing to multiple organ dysfunction and failure, and culminating with death. Here are the etiology and classification of shock. Various etiological factors are responsible for development of shock, and as per its etiology, it has been classified as follows: cardiogenic shock, hypovolemic shock, vasogenic shock, endotoxic shock, neurogenic shock, and anaphylactic shock. Now coming on to cardiogenic shock, it occurs due to low cardiac output due to a primary cardiac disorder. It may occur in conditions like myocardial infarction, in cardiac arrest, in case of congestive heart failure, and acute heart failure. The key features of cardiogenic shock are systemic hypotension, elevated heart rate, increased central venous pressure, increased oxygen extraction, and decreased cardiac output. The pump failure may be related to valvular or myocardial incompetence too. Coming on to mechanism of cardiogenic shock, for causes such as myocardial ischemia, myocardial infarction, and myocarditis, there is impaired myocardial contractility. As a result, there is decrease in the cardiac output. For causes such as tachycardia and bradycardia, there is abnormalities in the cardiac rhythm. And for acute mitral and aortic regurgitation, ruptured interventricular septum, prosthetic valve malfunction, there is cardiac structural disorder. As a result, there is intermixing of blood in various chambers and impaired myocardial contraction and blood flow. As a result, there is cardiogenic shock. Coming on to hypovolemic shock, it occurs when the circulating volume is reduced significantly, as in case of severe hemorrhage, excessive plasma loss in burns, severe vomition and diarrhea, in case of intestinal obstruction, in case of diuresis and pancreatitis. It is one of the most common form of shock in case of small animals. Coming on to vasogenic shock. Vasogenic shock is recorded in severe traumatic injury, prolapse of uterus, in case of severe burns, and major surgical operations and severe surgical pain. Coming to endotoxic shock, it develops due to endotoxins or toxins produced by microorganisms. Usually, gram-negative organisms are involved. Absorption of toxin from the intestine and mammary glands may also result in endotoxic shock, as seen in acute diffuse peritonitis and coliform mastitis. Coming on to neurogenic shock. Neurogenic shock is a life-threatening condition caused by irregular blood circulation in the body. Trauma or injury to the spine can cause this disruption. It occurs after damage to central nervous system, such as in case of spinal cord injury. Coming on to anaphylactic shock, it results due to an hypersensitivity IgE-mediated antigen-antibody reaction that causes mass release of histamine and histamine-like substances and development of shock. It results in massive vasodilation, and the vasodilation in turn decreases the relative circulatory volume, decreasing tissue perfusion and thus oxygen delivery to the tissues. And this leads to splenic contraction, tachycardia, myocardial and cerebral hypoxemia, cardiovascular collapse, and ultimately death. Now coming on to pathogenesis of shock, regardless of the etiology, there is a marked reduction in the effective circulating blood volume, due to which the cardiac output is reduced and hypotension develops. It also causes less supply of blood to various organs, and to overcome such alteration in the system, physiological compensation occurs and catecholamines are released. These catecholamines help in maintaining the blood supply to the vital body organs. Due to it, tissue anoxia starts to develop at other sites, and anaerobic glycolysis occurs as oxidative phosphorylation is blocked. This results in excessive accumulation of lactic acid and lactic acidemia and intracellular acidosis. As shown in this flow chart, in case of hypovolemic shock, hemorrhage, trauma, surgery, burns, dehydration, there is reduce in the effective circulating blood volume. As a result, there is reduced venous return to the heart, reduced cardiac output, then reduced blood flow. As a result, decreased oxygen supply to the various tissues, resulting in tissue anoxia and shock. In case of septic shock, gram-negative septicemia and gram-positive septicemia, there is reduced venous return to the heart, then the same procedure of the flow chart leading to an anoxia and shock, and same for cardiogenic shock, which directly starts from reduced cardiac output and reduced blood flow, decrease in the supply of oxygen leading to anoxia and shock. Now here is a diagram representing the various etiological causes of shock along with some of its symptoms. As you can see, in case of hemorrhage or severe fluid loss, as in hypovolemia, and anaphylaxis and sepsis that causes vasodilation, there is reduction of venous blood return to the heart. Also, in case of myocardial or vascular disease, there is impaired myocardial contractility. All of these causes result in the decreased cardiac output, and signs of hypotension are seen because of it. Now, due to decreased cardiac output, there is hypoperfusion of tissue, commonly observed as pale mucous membrane and clumsy skin. As a result of hypoperfusion of tissue, there is development of tissue anoxia, leading to failure of oxidative metabolism, leading to acidosis, thrombosis, hemorrhage, edema, and ultimately shock. Now, due to shock, changes in kidney in the form of acute renal failure develops. During shock, the glomerular filtration rate falls and the renal cortical blood flow is reduced. Renal hypoperfusion leads to ischemic damage, causing tubular necrosis and edema that obstructs the renal tubules. The loss of renal tubular function leads to increase in metabolic acidosis, hyperkalemia, impaired clearance of drugs and other compounds, and oliguria is seen. In case of shock, lesions in the gastrointestine is seen during post-mortem due to endotoxin absorption, as in case of endotoxic shock. Now, acute respiratory distress syndrome, ARDS, or lung failure is also seen in case of shock. Because lungs receive the entire cardiac output, they are involved in inflammatory components of shock more than any other system. Acute respiratory distress syndrome is a term that is used to describe lung injury caused by systemic inflammatory response. The inflammatory mediators and activated leukocytes like TNF, interleukin-1, etc. causes systemic inflammation throughout the body and target the pulmonary vascular endothelium and cause an activation of the pulmonary vascular endothelium. Pulmonary capillaries can then become plugged by leukocytes. The activated leukocyte then directly damage the capillary endothelium, exacerbating the inflammatory process. This exacerbation can lead to ventilation, perfusion mismatching, increased shunt fraction, and increased capillary leak, ultimately seen as a form of dyspnea as a clinical sign. Now, in case of gastrointestinal lesions, gastrointestinal bleeding and paralytic ileus are the common symptoms seen in case of shock. Coming on to pathogenesis of endotoxic or septic shock, generally endotoxins and other toxins in less amount cannot pass the intestinal barrier and are detoxified in the liver and excreted. However, in diseased animal, toxins in large amount easily passes the intestinal barrier and cannot be cleared by the liver and thus enters the systemic circulation to gradually result in shock. Here is the flowchart of endotoxic shock development. The toxin passes the intestinal barrier in large amount. As a result, the toxins enter the systemic circulation as it is not completely metabolized by the liver. It enters the systemic circulation as well as the peritoneal cavity. And this causes peripheral vasodilation and reduction in the circulating volume. And the toxin also starts damaging the endothelial lining, and severe anoxia occurs because of it. And there is production of arachidonic acid, which is a precursor for eicosanoids like leukotriene, prostaglandin, thromboxane A2. These are potent vasodilators, and these adversely affect the vascular reactivity and permeability, leading to toxic shock. Now, coming on to clinical findings of shock, the clinical findings vary depending upon the different stages of shock. It depends whether the shock is in a compensated or non-progressive stage, decompensated or progressive stage, or irreversible or refractory stage. In case of compensated or non-progressive stage, it is seen at the very beginning of shock when the body's compensatory mechanism tries to counter the decrease in the perfusion of tissue and decreased arterial blood pressure by increasing the sympathetic activity and splenic contraction to release the reserve blood to the systemic circulation. In case of progressive stage of shock, it occurs when the compensatory mechanism fails to reverse the decrease in the tissue perfusion. And in case of irreversible or refractory stage of shock, the patient dies. In case of non-progressive stage, the capillary refill time and the blood pressure remains normal. The normal capillary refill time being less than 2 seconds and the normal blood pressure being about 120 millimeters of mercury. The tachycardia and congestion are common signs of non-progressive stage, and the signs in this stage are indications of the affected animal is likely to suffer from shock, and necessary steps are to be taken as early as possible. Coming on to progressive stage, this is the stage when the patient suffers from some stress or risk factors besides the persistence of the shock, so that there is a progressive deterioration of the condition of the animal. The visible mucous membrane becomes pale grey or muddy. The capillary refill time is increased to 3 to 4 minutes. The animal becomes depressed. There is reduction in the venous blood pressure and the veins cannot be raised easily. The extremities become cold while the body temperature remains subnormal. Respiration becomes shallow and rapid. The heart rate is increased, that is tachycardia. There is weak pulse with small amplitude and low pressure. And upon skin turgor test, the skin resides at 10 to 30 seconds, indicating a dehydration percentage of 10 to 12%. Here are some pictures to show the clinical signs of progressive stage of shock. A cat with shrunken eyes and dilated pupils, the pale mucous membrane in eye in goat, and pale gums in dogs. In case of irreversible stage, this is the stage when the patient has irreversible physiological changes and multiple organ distress syndrome is noticed and the patient dies at this stage. Skin turgor test is more prolonged, more than 30 seconds, and dehydration status is 12% and more. The patient usually goes into coma and then death. Now, necropsy findings upon shock are dehydration, widespread petechial and ecchymotic hemorrhages. In case of endotoxic shock, there is congestion of capillaries and pulmonary edema may be recorded. Now, coming on to diagnosis of shock, it is based on history and clinical signs, measurement of arterial blood pressure, blood examination, and electrocardiography. The measurement of arterial blood pressure. A level below 100 mmHg indicates the presence of shock, the normal arterial blood pressure being 120 mmHg. If the pressure falls below 60 mmHg, the shock is usually fatal. History of illness along with clinical sign gives us an idea about the disease. Coming on to blood examination, there is reduction in the blood pH, that is acidosis, and elevation of eosinophil count. The hematocrit may or may not be increased. Creatinine and blood urea nitrogen levels are elevated, while the total protein may not be altered in all cases of shock. Coming on to electrocardiography, it is of value in diagnosis of cardiogenic shock. In myocardial ischemia, there is prolongation of the QRS interval and peaked or inverted T wave. Coming on to treatment of shock, the three most important concepts while dealing with shock are summarized by an acronym VIP, that is, V stands for ventilation to ensure a patent airway to maximize oxygenation and oxygen carrying capacity of the blood, I for infusion of fluid to restore vascular volume, and P maintenance of myocardial pumping function to restore cardiac output and blood flow. Now, elimination of the precipitating cause is a must, whether it be due to cardiogenic, endotoxic, or vasogenic, or any other. Fluid therapy to be given after assessment of fluid loss is essential to restore blood volume to prevent anoxia and tissue damage, and it should be done as soon as possible as it will help in restoring the circulatory function and tissue perfusion. Antibiotic therapy is important in endotoxic shock. Corticosteroids, cyclooxygenase inhibitors, betaadrenergic stimulators in cardiogenic shock is important. Now, coming on to fluid therapy for shock, crystalloid solutions are fluids that contain electrolytes, and crystalloids that contain sodium are the initial fluid of choice for treating patients with shock, as they are easy to administer, readily available, inexpensive, and effective. Shock initially should be treated aggressively with fluid containing adequate amount of sodium because of the relatively high concentration of sodium in the extracellular fluid. Readily available and commonly used isotonic solutions include 0.9% sodium chloride, lactated Ringer solution, plasma light, and normosol R. They should be given at a dose rate of 50 ml per kg body weight intravenously and can go up to 90 ml per kg body weight intravenously for dogs and 44 ml per kg body weight for cats. Now, plasma light and normosol R have an advantage over Ringer lactate solution for patients in shock, as the Ringer's lactate solution uses lactate as its primary buffer that needs to be metabolized by liver to form bicarbonate, and in case of shock, the hepatic metabolism is markedly impaired. Normosol R and plasma light, on the other hand, contain acetate and gluconate as the primary buffers, and they are metabolized primarily by the skeletal muscle to form bicarbonate, and hence they are more effective. Now, in case of colloid solutions, these are fluids that increase the plasma osmotic pressure and expand the plasma volume. Example of it are dextran, gelatin like hemacil, gelofuscin, etc. Now they are given at a much lower dose rate compared to crystalloid. Colloids are given at the generally dose rate of 10 to 20 ml per kg per day. The volume is given typically over 4 to 6 hours but can be given faster if needed. A common formula for fluid therapy is give 1/4 of the calculated shock volume within 15 minutes and then monitor the deviation from the baseline packed cell volume, total protein, etc. That is, replace 1/4 of the calculated fluid volume as rapidly as possible and then reassess the tissue perfusion parameters like heart rate, blood pressure, capillary refill time, and urine output. The fluids to be given in case of colloid solutions, as I mentioned before, are much lower, around 10 to 20 ml per kg per day, and can be given faster if needed. Now, large volume of isotonic solution may increase pulmonary artery pressure and result in pulmonary edema. To overcome such problem of large volume, colloid solutions like dextran, gelatin polymers or heta or hexa starch may be used. The colloid solutions are costly and it may induce coagulopathy and pulmonary edema. To overcome such problems, an isotonic solution should be given initially and then small amount of hypertonic saline solution is used. For this purpose, 7.2% saline solution can be used at the rate of 3 to 4 ml per kg body weight. They are helpful in withdrawing the intracellular and interstitial space water into the vascular compartment. Small volume of such fluid helps in transcompartmental and transcellular shift of fluid into the vascular compartment, and it leads to an increase in the circulatory volume. As a result, there is increase in cardiac contractility, increase in the stroke volume, and increase in the blood pressure, and this reduces peripheral and pulmonary vascular resistance. Now, antibiotics are desirable in case of endotoxic shock as there is involvement of bacterial agent. Now, they may not actually cure, or should I say they should not actually neutralize the endotoxin, but it is useful in reducing the number of microbes. Broad spectrum antibiotics or combination of antibiotic should be given for at least 3 to 5 days. Corticosteroids, usually glucocorticoids like dexamethasone, is used at the dose rate of 5 to 10 mg per kg body weight intravenously, and COX inhibitors, which is non-steroidal and anti-inflammatory drugs like flunixin meglumine, is a beneficial in case of endotoxic shock. They inhibit the production of vasoactive prostaglandin and thromboxane A2. Recommended dose is around 0.2 mg per kg body weight. Beta-adrenergic stimulators are helpful in cardiogenic shock in affected animals in which the circulating blood volume has been restored. The use of beta-adrenergic drugs like isoproterenol is valuable at a dose rate of 0.02 to 0.06 mg per kg body weight intravenously as bolus infusion, and then 0.01 to 0.02 mg per kg body weight intravenous as subsequent dose. However, its use in case of hypotension will further aggravate the condition of the animal, as isoproterenol is both a beta-1 and beta-2 agonist. So, if there is hypotension, then isoproterenol will act on the beta-2 receptor of the blood vessel supplying skeletal muscles and cause vasodilation, further aggravating shock. Now, dobutamine is the drug of choice in case of cardiogenic and septic shock to restore the cardiac output and oxygen delivery comparably more better than dopamine. Dobutamine is used at a dose rate of 5 to 15 micrograms per kg per minute intravenously for dogs and cats. Dobutamine at a dose rate of 1 to 5 micrograms per kg per minute intravenously is used to increase the cardiac output. These were the sources of today's presentation. And that's it. We hope you enjoyed this presentation. Thank you.